Dr. Ken Landau. Thanks for watching. Let's talk about obstructive sleep apnea, or OSA. It's a very common, often unrecognized condition, and it's associated with either complete or partial obstruction of air passing through the throat into the airways. The person has multiple episodes during the nighttime, and they're associated with frequent awakenings. Now, the awakenings may last only for a millisecond or up to 10 or 15 seconds. Often the patient and the bed partner completely unaware of the occurrence of these awakenings. But if a person were to be tested with an electroencephalogram, it would be obvious what's happening. But the clinical manifestations are what's important. And these multiple nighttime awakenings cause a person to suffer from excessive daytime sleepiness. Well, what's the incidence? The incidence has increased by about 50% since the 1990s. It's 2 or 3 times more common in men than women, and depending on the definition and the patient population, it appears to be present in about 5 to 15% of the general population. And if we look at middle-aged individuals, it's 20 or 30% who suffer from the condition. And if we look at obese individuals, fat individuals, then it's in excess of 50%. The incidence increases up to about age 65 or so, and then it seems to level off. Now, if we really make a more restrictive definition, it still would be present in about 4% of men and 2% of women. Now, there are several different types of sleep apnea. We have obstructive sleep apnea, where even though the person is still making respiratory efforts, the air is blocked at the level of the throat or the pharynx. Then we have central sleep apnea. The person is making no respiratory efforts whatsoever for at least 10 seconds, and that occurs repetitively during the nighttime, frequently associated with heart failure, maybe a complication of obstructive sleep apnea, however. Then we have mixed apnea, both central and obstructive apnea together in an individual. We have Pickwick syndrome that occurs in people who are unresponsive to elevated levels of carbon dioxide in the bloodstream, usually very obese additionally. And then there's a new condition, and the new condition is known as upper airway resistant syndrome. And this condition is associated with snoring, with repetitive arousals at night that can last up to 10 or 15 seconds, with excessive daytime sleepiness. So it looks exactly like the obstructive sleep apnea, except for one major factor. They don't have those pauses in the respirations at nighttime. Well, if we look at obstructive sleep apnea, it's composed of 2 different components. We have apnea and hypopnea. Apnea means the total complete obstruction of airflow, even though you're trying to breathe, even though the muscles are still working. And we have no passage of air for at least 10 seconds. In hypopnea, we have more than a 50% reduction that still lasts for more than 10 seconds, or we can have moderate airflow reduction in the presence of oxygen desaturation in the bloodstream, or we can have a moderate airflow reduction with electroencephalographic evidence of awakening. Well, the way we look at obstructive sleep apnea is we add up all of those episodes of apnea and all of those episodes of hypopnea during the nighttime, and we divide it by the number of hours a person sleeps. And then we can say whether the person has mild, moderate, or severe disease. It's mild when they wake up every 4 to 15 minutes. It's moderate when they wake up every 2 to 4 minutes. And it's quite severe when they wake up more frequently than every 2 minutes. And that's why these people suffer from excessive daytime sleepiness. Now, the diagnostic criteria are an AHI, that's the apnea-hypopnea index that we just talked about. So when they have an apnea-hypopnea index of at least 5, plus either excessive daytime sleepiness or at least 2 symptoms, and the symptoms are choking or gasping during sleep, or recurrent awakenings from sleep, or unrefreshing sleep, or daytime fatigue and impaired concentration. Any of those make the diagnosis of obstructive sleep apnea. Or the diagnosis could just be on the AHI, the apnea-hypopnea index alone, if it's at least 15. Now, what's the cause? Cause basically, 70 or 80% of the time, is obesity. People are just too fat, and fat seems to lead to obstruction, either partial or complete. We're even finding it now in obese children. If you gain 10% of your body weight, you're going to increase the prevalence of obstructive sleep apnea 600%. If we look at normal weight men, the incidence is about 10%. If we look at overweight but not obese men, it's about 20%. If we look at obese men, it's in excess of 60%. Women, normal weight, about 3%. Overweight, about 9%. Obese women, about 20%. Well, if we look at the age, we're going to find that it seems to peak somewhere between the ages of maybe about 30 and 60 or 64. We have separate criteria that are appropriate for people over age 65. Postmenopausal women seem to have a much higher incidence than premenopausal women, and it has to do with the lack of hormones. Obstructive sleep apnea occurs much more frequently in African Americans than it does in Caucasians, especially at a younger age, and it seems that there's some genetic input from the leptin hormone or the leptin receptor. That has to do with body weight. The symptoms tend to begin sometime around puberty when the sex hormones are produced. Typically it goes on for years without any diagnosis. These are people who typically snore quite loudly. Their sleep is interrupted by choking or gasping or snorting. They have the frequent awakenings, the fragmented sleep, and then they suffer from excessive daytime sleepiness. Now, you can be excessively tired in the daytime and not have obstructive sleep apnea. That's certainly a very common condition too, but when you put it all together, very frequently associated with obstructive sleep apnea, the person is oftentimes unaware of the condition, but the bed partner is frightened because of the cessations or the pauses or the halting of respiration, and then the noises and the gasps and all of the other flailing about of the arms and the legs that are associated with this condition. And when it occurs repetitively, as a matter of fact, the spouse often moves out of the bedroom. And interestingly, the snoring can be so loud that it would exceed the OSA limits for a safe workplace. So we have these repetitive episodes. We have the loud snoring, the irregular cycles of breathing, then we stop. Then are the snorts and the gasps and the grunt and the flailing of the arms, and then we start all over again. And remember, this can happen as frequently as every 2 minutes. Well, snoring is from a decrease in the upper airway size and an increase in the upper airway resistance, and that leads to vibration, and it's the vibration of the soft palate and the uvula and the lateral walls of the pharynx that lead to the snoring. And with all this vibration, the uvula, the little thing that hangs down in the back of your throat, that becomes swollen and edematous, and that takes up more space and is likely to cause more problem with the respiration. And then we have excessive daytime sleepiness. Obviously, that's a significant problem. So that people fall asleep during sedentary activities. So you're watching the television, fall asleep. Unfortunately, driving a car and fall asleep. Often these people wake up in the morning with frontal headaches or generalized headaches. They have sore mouth because they frequently are mouth breathers. They have a sore throat on awakening. Sometimes they're hoarse with a nasal voice. And all of this activity during the nighttime, the flailing about, that burns up calories. That increases the metabolism and oftentimes causes a person to perspire at night, so you wake up wet. And the lack of sleep can lead to significant problems, irritability and anxiety and depression and agitation and restlessness in the daytime, poor memory, difficulty concentrating, poor judgment, a condition that we call sleep drunkenness, where it appears that the person's confused in the morning and disoriented. There's a decrease in libido, and erectile dysfunction seems to come along with it. And oftentimes people notice some swelling of the ankles during the daytime, and that leads to excessive nighttime urination and sometimes even bedwetting. What's the cause of obstructive sleep apnea? 70–80% of the time, it's due to obesity. There's too much fat, and the fat is in the wrong spot. What's the wrong spot? Well, it could be around your neck. People have a fat neck. Or it could be there's some deposition of fat in the tongue. But more likely, it's going to be excessive fat on the trunk or in the body, on the chest, on the ribs, and the abdomen. And postmenopausal women seem to deposit more fat than premenopausal women. And sometimes the fat happens to be around the pharynx. And then sometimes people develop a double chin. Sometimes it's a genetic factor, but sometimes it's due to excessive weight. And when these people lie down, and they lie down on their back, then all of those tissues and the tongue falls back and further occludes, further narrows the breathing passageways. And then in REM sleep, muscles become paralyzed. The only thing that works seems to be the diaphragm. So the diaphragm is the only part that is trying to get the air in against all of the increased obstruction. Well, another problem is that people who have obstructive sleep apnea may have an overbite, and an overbite is associated with pushing back of the lower jaw or the mandible, and the tongue is attached to the mandible, so the tongue is pushed back in people who have an overbite, and that further leads to complications. And then there are people who have nasal or postnasal obstruction because of allergies or deviated septum or enlarged tonsils or adenoids. And then sometimes we have a subtle change. It's a little bit enlargement of the tongue because of obesity, because of hypothyroidism. And some people have anatomic abnormalities, maybe a high-arched palate or a long, soft palate, or redundant tissues, or inferior displacement, backward displacement of the hyoid bone that sits right on top of the trachea. Some of these people have a long pharynx. That means there's more potential for obstruction. Sometimes people have a diminished lung volume, and the sex hormones are obviously very important because the sex hormones, especially in men, lead to an increased bulk of the tissues around the pharynx. And the pharynx is a collapsible tube. It doesn't have any skeletal support. The purpose of the pharynx, of course, is for speech and swallowing and respiration. During normal inhalation, when you breathe in, you're going to generate some negative pressure in your chest. That's going to promote a collapse of your pharynx. But we have some dilator muscles and some reflexes that keep it open. But when you go to sleep, those reflexes also go to sleep. And you're more likely to have some obstruction. When we look at people who are awake, who have obstructive sleep apnea, we find that their upper airway tends to be a little bit smaller than in people who don't have obstructive sleep apnea. Not only that, when they're lying supine, the pharynx tends to assume an elliptical position. And in an elliptical position, it's more likely to collapse than it is if those same individuals sleep on their side or lie on their side, in which case the pharynx assumes an oval position. And when a person lies on their back, they're twice as likely to have an apnea-hypopnea index. So we have people who are already prone to obstruction. And then when we have the obstruction, we know that the air is going to pass much more rapidly past an obstruction. And there's a principle of physics, the Bernoulli principle and the Venturi principle, and they suggest that wherever there's an obstruction, the flow is going to be faster. And when the flow is faster, it causes a decreased pressure on the lateral pharynx, and that means there's even more tendency to obstruct. So all of this together causes major issues. What are the major issues? What are the consequences or the sequelae of obstructive sleep apnea? They are immense. So if we talk about brain function, it occurs in all domains of the brain, of neurocognitive function. So people with obstructive sleep apnea have problems with attention and concentration and memory. They have visual spatial problems, psychomotor problems. They have problems with executive function. Executive function is the ability to develop and sustain a planned attack on a problem. If we do an MRI, they'll have decreased gray matter. There's neurodegeneration that occurs in the hippocampus. And it's also significantly associated with high blood pressure. High blood pressure, not only the systemic kind that we measure with a cuff on the arm, but also high blood pressure of the pulmonary artery inside the lungs. And that's a major issue. And it gets to a point where we have drug-resistant hypertension. So you go to the doctor and he says you have high blood pressure and you get the standard treatments and it doesn't seem to work. It may well be because you have obstructive sleep apnea. Worsened, by the way, because of that obesity, because of your age, because of alcohol you might drink or cigarettes. And then not only do we have high blood pressure during the day, but we also have non-dipping blood pressure during the night. When you go to bed at night, typically your blood pressure is going to fall by about 10 or 20%, but it doesn't do that in obstructive sleep apnea. And it's that nighttime dip in your blood pressure that helps protect you from heart failure and coronary artery disease and a variety of cardiovascular consequences. But you don't get that if you happen to have obstructive sleep apnea. Well, additionally, obstructive sleep apnea is associated with a metabolic syndrome and diabetes and heart failure and arrhythmias and stroke, and it's associated with depression. And if we look at the incidence of atherosclerosis, hardening of the artery, seems to go along with the severity of the sleep apnea. So if we look at sleep apnea, the severity is going to correlate with the narrowing of the carotid artery leading to your brain. We have a significantly greater likelihood of atrial fibrillation and ventricular tachycardia and ventricular fibrillation and heart block, and even significant slowing of the heart rate before it races up. So before you wake up, the heart rate seems to be relatively slow, and then when you wake up, when all of this is happening, when you don't have the oxygen, the heart rate is going to go significantly higher. And it's even worse if you happen to have been a smoker and you have chronic obstructive lung disease as well. Well, additionally, you have a higher chance of suffering from heart failure because of all of the pressure that's being put to bear on the heart. And then you have a higher incidence of developing gastroesophageal reflux, heartburn, because of all of the exaggerated negative pressure in the chest that's sucking the stomach contents up into the esophagus. Well, oftentimes the patient comes in complaining, not of obstructive sleep apnea, of course, but they complain of excessive daytime sleepiness, and the bedmate says, hey, he keeps waking me up at night because of all this flailing about. Sometimes the patients are asleep in the waiting room. Well, the standard blood tests are appropriate to make sure everything else is okay, so a complete blood count, metabolic profile, thyroid tests, blood pressure, heart evaluation, some lung tests, but we don't need any kind of fancy X-ray tests, imaging tests, MRIs, or CAT scans. The way the diagnosis traditionally is made is with a sleep laboratory, polysomnography it's called. That's the gold standard. It's expensive, but you spend a night or 2 nights in the sleep laboratory, they confirm the diagnosis, they assess the disease severity, and they can give a guide to therapy. They study a variety of different functions. They look at how much oxygen you have. They look at your electrocardiogram. They check the activity of your muscles with an electromyogram. They check the movement of the eyes with an electrooculogram. They check your chest wall movements and the airflow through your nose and through your mouth. And they assess the snoring. It's expensive, but it's really not necessary for the standard patient. Simply monitoring the oxygen saturation at home is probably going to be sufficient. Now, there's some errors that occur, but that's in a minority of patients. And sometimes we could do a test in between the two. We could do some respiratory polygraphy just check the respirations alone without doing those electroencephalograms and the electroculograms. Well, the treatment, what is the treatment? Well, let me see. If you're too fat and you have a consequence of the disease, and you're probably going to be diabetic and you have high blood pressure as well, treatment is lose weight. And if you lose weight, you're going to decrease that AHI, the apnea-hypopnea index, by somewhere in excess of 50%. And then you can even do better if you get some exercise, because the exercise increases your respiratory drive. You have to avoid certain kind of things, so you should avoid alcohol and sedatives. You shouldn't be popping Xanax, and certainly stay off the hydrocodone and the oxycodone. And you should sleep either on your side or on your belly. You should not sleep on your back. And if you traditionally sleep on your back, well, then go sew a golf ball or a tennis ball or something like that in your nightshirt, and that'll keep you from sleeping on your back. Or you can elevate the head of the bed by about 30 degrees. We had some medicines, but the medicines never really worked well. They were the old-fashioned antidepressants medicines like protriptyline or the serotonin agents. Sometimes progesterone was used. And even sometimes the drugs that we use to treat asthma, drugs like the methylxanthines or the theophylline. And interestingly, so too with the narcotic antagonists. They seem to be at least a little bit helpful. But those aren't really the standard therapy. Standard therapy is, one, lose weight, and two, consider an oral device that moves the mandible, the lower jaw forward, moves the tongue forward. They're not very expensive, they're not obtrusive, they don't make any noise. Patients prefer them to the CPAP machines. There's more than 70% compliance. And as a matter of fact, overall, clinically, it seems that they give you just about the same amount of benefit in the long run as the CPAP machines. Now, the oral devices work by opening up or widening the upper airway, and they help prevent upper airway collapse. They're good for mild to moderate disease. The CPAP machines, that's supposedly the treatment of choice, but it's a pain in the neck, and the supposed benefits are arguable. So a lot of people say that CPAP is going to be able to decrease the cardiovascular mortality and morbidity and improve your blood pressure. It does by about 2 millimeters. It's supposed to decrease the arrhythmias and decrease the likelihood that you're going to have a fatal or non-fatal heart attack or stroke. And it's arguable whether that really occurs. We know that people tend not to be very adherent to the CPAP. In Europe, the adherence is relatively high. It's 65 to 80%. Here in the United States, it's very low. And interestingly, the compliance with the CPAP has nothing to do with the severity of disease, nothing to do with the oxygen saturation in your blood, and it has nothing to do with the nighttime problems and flailing about. The reason people use the CPAP machine is because of that excessive daytime sleepiness. More excessive daytime sleepiness, more compliance with the CPAP. Well, unfortunately, even if you comply with the CPAP machine and you haven't lost weight and you haven't done any of the other things that are really appropriate, still about 10 to 40% of the people are going to suffer from excessive daytime sleepiness. Sometimes it's because of just the obesity, and the obesity leads to inflammation and a lot of other changes, and diabetes and depression. And sometimes there's just irrevocable damage to the lungs. And CPAP is poorly tolerated by a lot of people. It leads to irritation or pain or rash or skin breakdown, frequently dryness of the throat, nasal congestion, and runny nose in some people. And when the air escapes from the mask, it can lead to eye irritation or claustrophobia or movement problems. It restricts your movement. And sometimes some of the air gets down into the gut or the bowel and you get abdominal distension. And sometimes it may lead to an increased incidence of ear or sinus infections. And you can imagine the aggravation of traveling with a CPAP machine, or what happens if you're dating or if you're involved in some sort of intimacy and you got this gadget that you have to bring with you. And if it's a little bit worse and you still don't do better with the CPAP machine, there's the BiPAP machine, which is the bilateral positive airway pressure machine. And then we have bariatric surgery. We said that the problem is that people are too fat. So they believe that you can go and correct the problem with bariatric surgery, either the balloon or some more significant surgical intervention. And indeed, it's quite helpful. And we can reduce the number of episodes by 30 or 40 per hour, but it rarely cures the disease because most people lose weight, but they still are overweight. There's surgery on the airway. You can have surgery on the airway. That's associated with increased risk, no guarantee. And oftentimes, there's more than one level of obstruction that occurs in an individual. So there's a high rate of success, but for a minority of patients. Surgery on the upper airways, of course, modifies the airway, but we don't really have good controlled studies, and we don't have any standardized criteria for what's successful. We could also perform surgery to move the lower jaw, the mandible. We could move it forward. And if we move it forward, then we can move the tongue forward, and we can move the hyoid bone forward, and we correct some of the problem. And that would be okay. Then there's the uvulopalato-pharyngoplasty. That's a more invasive surgery. And what happens is they take out the the tonsils and the adenoids, and then the uvula, that thing that hangs down, and they do some remodeling of the posterior portion of the palate, and they reorient the tonsillar pillars, and people have some pain for a couple weeks after, maybe a little loss of taste, nasal speech that can come, maybe the tongue is numb for a while. It's not seemingly for really severe disease. We can perform some laser surgery or radiofrequency ablation. All of that seems to get around the margins of the disease, but the principal problem in 70 or 80% of the people is they are just too fat. So what is the treatment? Is the treatment go through all of the surgery and go through the CPAP and the BiPAP machine and all of that? Or is it to lose weight? I can't lose weight. I've been on all sorts of diets and not been able. That's because you're on the wrong kind of a diet. The right kind of a diet, apparently for most people, would be to follow a low carbohydrate. Here in the United States, we follow a high carbohydrate. You need a low carbohydrate diet with high amount of fat, high amount of protein, and that kind of diet seems to be more successful. But whatever, you should always get a second opinion because there's so much uncertainty with regard to obstructive sleep apnea. You shouldn't sleep on your back, you should sleep on your side, and obviously you should eat better, you should get some exercise, and you should consider that obstructive sleep apnea is just another manifestation of the complications associated with obesity. So it's just like having high blood pressure, having diabetes, having high cholesterol. We have all of these things that go in the aftermath of being fat. So is the treatment get some surgery, go through all of these invasive procedures and have a noisy machine clanging at your bedside? Or should you just change your diet? Should you not pay any attention to all of the ads for the fast food and the bad food? I would say if that sort of rings a bell, if you've always wanted to lose some weight, then you ought to consult with somebody and talk about a diet that's appropriate for you. Anyway, I thank you for watching. I'm Dr. Ken Landau.